I think I discussed that when we took a class on adenotonsillectomy anesthesia. Supposing the surgeon and the anesthetist know that adenoidectomy is also going to be done, what route of intubation they could have resorted to?
We preferred oral route, sir.
They could have gone for an oral ray tube. Then this problem can be totally avoided. I think I put it up in one of the slides, which route to intubate, whether to go for oral or nasal, and discuss with the surgeon that if you are planning to do an adenoidectomy combined with tonsillectomy, go for oral intubation with a ray tube. And if you are planning only for tonsillectomy, then you go for a nasal intubation, so that surgeon will have a more free space to operate. But nowadays, with all the blades which come with a groove to adopt the oral route intubation tube also in the middle without getting kinked or compressed. So that could have been done by discussion with the surgeon prior to, because it's an elective procedure. After all, adenotonsillectomy is not an emergency procedure. So they could have done that, and this problem could have been totally avoided. As you rightly said, it is only God's grace that the child came out without any complication. Otherwise, intubating a 3-size tube inside a 5.5 and then trying to ventilate through a narrow tube, producing a negative pressure pulmonary edema. And we do not know whether the child was breathing spontaneously or whether they have controlled that. The details is also not given. So if the child is allowed to breathe through a 3.5 tube, definitely within 5 minutes, the child is likely to develop a negative pressure pulmonary edema also. Okay? So all these problems. Kamachi, are you there?
Yes, sir. Good evening, sir.
Good evening. Shall we start?
Yes, please, sir. Good evening, respected professor and my dear students. I welcome you all to another session of ASA DNB and online academic activities. Today we have clinical case discussions along with, if time permits, we'll have some OSCEs also. The first presentation I hand over to Dr. Vidhya to present the case on 24 years old primey with 24 weeks of gestation admitted with dyspnea on mild exertions. It's a known case of mitral stenosis, diagnosed 2 years before and is on medical management. How to manage? Over to professor and students. Thank you, sir.
Thank you.
So good evening, sir.
Good evening, Vidhya. Go ahead.
Yes, it is a 24-year-old primey, 24 weeks of gestation with mitral stenosis, sir. So mitral stenosis refers to decrease in the mitral valve area. Normal mitral valve area is 4 to 6 centimeters square. Since the patient is symptomatic and is a known case of mitral stenosis, we'll start with the assessment of type and the severity of the disease, and we have to assess the functional status of the patient. On evaluation, the purpose of evaluation is to assess the risk, to stratify the risk, and to reduce the risk, and we have and management to mitigate the complications, which includes complete cardiac history, physical examination, and investigations. From history, we have to elicit symptoms such as breathlessness, hemoptysis, cough, which indicates increase in the left atrial pressure and the pulmonary congestion. History of any fatigability, syncope because of decreased cardiac output. History of chest pain, palpitation, which can be due to arrhythmia or atrial fibrillation, and any leg swelling, edema because of right heart failure. And clinical signs on inspection, mitral fascias, which is a pinkish purple patch, or malar fudge, which usually not seen in Indian patients. And the patient can have raised JVP, ascites, pedal edema, which could be the signs of right heart failure. On palpation, we have to look for the pulse. Usually it is a regular low volume in the absence of atrial fibrillation. It will be irregular pulse in case of atrial fibrillation, and the patient can have left parasternal heave if right ventricular hypertrophy present, tapping apex beat, And on palpation, there will be a diastolic thrill at the cardiac apex with the patient in the left recumbent position. On auscultation, we could hear a loud S1 opening snap, a mid diastolic murmur. Based on the severity, murmur intensity varies. And we can also hear crepitations because of pulmonary edema, loud P2 in case of pulmonary hypertension, and right ventricular heave. Investigations which includes routine complete blood count, renal function test, liver function test, coagulation profile, along with that pertaining to mitral stenosis. ECG, we have to look for P mitral, which is bifid P wave in lead 2-3 AVF, which is a sign of left atrial enlargement, and large dominant R waves in lead V1, V2, which is a sign of pulmonary artery hypertension. And we have to look for right axis deviation in case of right ventricular hypertrophy, and we have to look for any arrhythmias or atrial fibrillation. Signs of chest X-ray. Chest X-ray is usually contraindicated, only done that too with abdominal shielding. We have to look for straightening of left heart border because of left atrial enlargement, double density sign, and we can also look for any calcified mitral valve in the chest X-ray, evidence of pulmonary edema or pulmonary congestion like curly B lines. In echo, we can look for a degree of leaflet thickening, degree of calcification, changes in the mobility and the extent of involvement of valvular apparatus. We can look for mitral valve area. We have to measure the transvalvular pressure gradient, and we can also look for chamber dimension. We have to look for the presence or absence of pulmonary artery hypertension. We have to look for the ventricular functions or any other valvular diseases. So with the help of echo, we can grade the severity of mitral stenosis with the help of valve area, transvalvular mean pressure gradient, and pulmonary artery pressure. Cardiac enzymes which are not specific in pregnancy, cardiac imaging like cardiac MRI can be done. Cardiac catheterization should be restricted to interventional procedures during pregnancy along with abdominal shielding. After examination and assessment, we have to assess the risk with the help of NIHA score or heart failure stage classification, or CAR-PREG score, which is cardiac disease in pregnancy score, or modified WHO risk scores. Since the patient is having dyspnea and mild exertion, she comes under NIHA classification 3, and she is high risk for a pregnancy. Management includes multidisciplinary approach, which includes the obstetrician, anesthesiologist, and the cardiologist. If the patient comes preconceptional with a severe MS, we have to counsel the patient against pregnancy, and also we have to educate the patient regarding the disease, its cause, and the possible impact on mother and the fetus. Usually, the patients with mild to moderate MS will well tolerate the pregnancy, and they'll be on medical management. Medical management includes bed rest, salt restriction, and use of diuretics, beta blockers to control the heart rate, digoxin and beta blockers to control atrial fibrillation if present, and anticoagulation in case of atrial fibrillation or with the patient with left atrial enlargement who are high risk for atrial fibrillation. In symptomatic patients where medical management has failed, and if the mitral valve area is less than 1 centimeter square, interventional procedures should be considered. Based on the echo Wilkins scoring, we have to select the patient who are suitable for percutaneous mitral valvulotomy, and the procedure of choice is balloon mitral valvuloplasty. It is ideal to perform between 12 to 14 weeks where there is decreased fetal radiation exposure. Since this patient is 24 weeks of gestation, she can be, if she can be stabilized with medical management, we can delay the procedure to 26 to 30 weeks to decrease the risk of preterm delivery. And if the patient is with a severe MS and with pulmonary artery hypertension, termination of pregnancy should be considered. And also wherever the patient is, where percutaneous mitral commissurotomy is not an option, termination of pregnancy should be considered. Anticoagulation in pregnancy, initially till 12 weeks, till first trimester, the patient should be on unfractionated heparin or low molecular weight heparin. From 12 weeks to 36 weeks, warfarin should be considered. Along with it, aspirin, low dose aspirin is recommended in second and third trimester. Then from 36 weeks, warfarin should be stopped and the patient should be bridged with unfractionated heparin or low molecular weight heparin. Goals and the pre-optimization of a patient with mitral stenosis is maintenance of low normal heart rate, maintenance of sinus rhythm. We have to treat atrial fibrillation if present, avoidance of aorta cable compression, maintenance of adequate preload to avoid increase in the preload to prevent pulmonary edema. At the same time, to avoid decrease in preload to prevent decrease in the cardiac output. We have to maintain adequate SVR, appropriate use of phenylephrine to maintain the systemic vascular resistance, prevention of pain, hypoxia, hypercarbia, and acidosis, which increases the pulmonary vascular resistance. Pre-optimization, we have to evaluate the fluid status, and then we have to stop diuretics on the night of surgery. We have to look for the electrolytes on the day of surgery. To continue digoxin, beta blocker, and calcium channel blockers perioperatively. Low molecular weight heparin, if it is a prophylactic dose, it should be withheld 12 hours prior to surgery. If it is a therapeutic dose, it should be withheld 24 hours prior to surgery. If it is unfractionated heparin, it should be withheld 6 hours before surgery. Warfarin should be stopped at least 5 days prior to surgery. Anti-aspiration prophylaxis and antacid prophylaxis with a proton pump inhibitor or H2 receptor antagonist and metoclopramide should be considered. Arrange for adequate blood and blood products. Infective endocarditis prophylaxis is not recommended except in high-risk group, such as the patient with a prosthetic valve or patient with a history of infective endocarditis. And when it comes to obstetric and anesthetic management, the management varies based on whether the patient is going for a vaginal delivery or cesarean delivery. When it comes to cesarean delivery, it is based on central neuraxial blockade or general anesthesia. Usually with mild to moderate mitral stenosis, the patient can tolerate vaginal delivery. Labor epidural analgesia should be considered in case of vaginal delivery. In the first stage of labor, labor epidural with opioids along with a small dose of local anesthesia to maintain analgesia in the second stage of labor. In the third stage of labor, there is high risk of cardiac decompensation because of autotransfusion. So we have to closely monitor the hemodynamics. Patient with high risk like NIHA 3 and 4, we can opt for invasive blood pressure monitoring. And throughout the delivery, we have to maintain the left uterine displacement. In case of cesarean delivery, that is patient with severe MS, NIHA 3 and 4, presence of pulmonary artery hypertension, and with some other obstetrical indication. For cesarean delivery, the treatment of choice would be central neuraxial blockade or general anesthesia. A patient with mild to moderate MS, valve area more than 1.5 centimeter squares with no pulmonary hypertension, we can consider central neuraxial blockade. In that epidural, spinal and combined spinal epidural, the technique of choice is combined spinal epidural, which offers a rapid onset and better analgesia, less maternal hypotension. It also provides post-op analgesia. Technique of GA, if the patient's valve area is less than or equal to 1.5 centimeter square or less than 1 centimeter square, patient with pulmonary artery hypertension who has a refusal to central neuraxial blockade or other contraindication to central neuraxial blockade. We have to keep emergency drugs ready, difficult airway cot and defibrillator ready. Attach all monitors as per ASA standard. We have to secure arterial line and central venous pressure. Since it is a high risk patient, we have to monitor urine output and temperature. Fetal heart rate should be monitored during induction. Patient is positioned in 15-degree left lateral tilt or with the help of the wedge on the right side. Pre-oxygenation for 3 to 4 minutes. Modified rapid sequence anesthesia using etomidate, where etomidate is the drug of choice. Also, we can use propofol or thiopentin with the titrated to the FF. Scoline or rocuronium can be used. We should avoid ketamine. We should avoid muscle relaxants with histamine release, which will lead to hypotension and tachycardia and worsen the condition. We have to avoid laryngoscopy responses with the help of a minimal dose of remifentanil or IV lignocaine or IV esmolol. We have to avoid nitrous during maintenance. Maintenance of anesthesia is with oxygen and sevoflurane. We can use short-acting beta blockers like esmolol to avoid hemodynamic fluctuations. We have to titrate the intraop fluid to avoid fluid overload, also to avoid decrease in the cardiac output. Avoid intraop hypoxia, hypercarbia, and acidosis. Oxytocin is administered as soon as the baby is delivered. We have to avoid iterotonics such as methyl ergometrin and carboprast. Reverse the patient slowly since the anticholinergic will increases the heart rate and lead to tachycardia. Extubation should be smooth. Avoid fluctuation in hemodynamics. Post-op management, continuous vitals monitoring for next 72 hours because the return of cardiac output, increase in the cardiac output because of autotransfusion continues till 3 days postpartum. So continuous vitals monitoring is important till next 72 hours. Inotropic support and vasodilator therapy should be continued at least for 24 to 48 hours. We have to avoid hypothermia, which will lead to shivering and increase in the myocardial demand. Judicious fluid administration. Multimodal analgesia using systemic opioids, paracetamol, NSAIDs. Also, we can opt for transverse abdominis block, quadratus lumborum block, or we can use an already placed epidural or continuous spinal catheter for post-op analgesia. Resumption of anticoagulation. Warfarin can be restarted 24 hours post-operatively after looking for the bleeding and the thrombotic risk. Therapeutic low molecular weight can be resumed after 12 hours post-operatively. Early mobilization should be considered. That's all, sir.
Very good. That was an excellent detailed presentation. Normally, the cases given like this are classified under pregnancy complicated by medical diseases, isn't it? That is the category under which these cases like valvular diseases or ischemic heart disease or cardiomyopathy or other respiratory problems, they are all classified under pregnancy complicated by medical diseases. And normally, when a patient has a mitral stenosis, majority of the times they are unaware of the problem that they have a mitral stenosis, and it comes to the fore only during the second trimester or the early third trimester when the maximum fluid volume increases in the patient. As you know, the points that are missing in your beautiful presentation are you have not gone into the details of how the patient came to know that she is a mitral stenosis patient, because I have specifically given that the diagnosis has been made 2 years prior to the patient becoming pregnant. So normally, what is the etiology of mitral stenosis?
Most commonly,
2 years ago, probably what is rheumatic heart disease, rheumatic fever and rheumatic heart disease. So that history and that elaboration is a little bit important if they give a scenario like this, saying that patient already has been diagnosed with mitral stenosis. So what are all the points that are important to elicit in the history of a patient who has already been diagnosed? How do you find out whether she has suffered any rheumatic fever during her younger days or not?
Sir, history of fever, throat infection associated with joint pain and
What type of joint pain?
is polyarthritis, usually multiple migratory polyarthritis.
Migratory or fleeting joint pain. That is the most classical or pathognomonic feature that has to be mentioned. Okay, it doesn't affect all the joints at the same time. It affects the ankle, then it affects the knee, then it comes to the hand, elbow, shoulder, like that. So it's a fleeting or migratory polyarthropathy with fever. Starts with the initial sore throat, which is very common in childhood for all of us who have undergone that. And which particular organism is important, because the questioning in the practical exam may be completely about rheumatic fever, even though they give a scenario saying that a patient is a pregnant patient with mitral stenosis. All the questions may be completely concentrated only on rheumatic fever. Okay, so all the details about the rheumatic fever you should be aware of, so that you can answer those questions. So how do you define, or what is the description about rheumatic fever? How do you describe the rheumatic fever? You said about the characteristics of rheumatic fever.
Yes, sir.
Is it an infective or a non-infective fever?
It is a non-infective autoimmune.
It is an autoimmune. What exactly happens in that? Which is the
There is a
offending
molecular
organism?
mimicry. There is a molecular mimicry between the organism and the fibrous tissue in the human body, sir.
The fibrous tissue or the antibodies against the
antibodies against the fibrous tissue.
So the actual description or definition of rheumatic fever is described as this. It is an acute, non-suppurative, autoimmune connective tissue disease which is self-limiting. Okay, so this is the which is preceded by a sore throat caused by beta hemolytic streptococci, Lancefield group A origin. Okay, so that is the definition of rheumatic fever. It is an acute condition. It doesn't produce any pus, so it is called non-suppurative, and it is a autoimmune disorder which affects mainly the connective tissue, initiated by infection with beta hemolytic streptococci, Lancefield group A. Why it is called Lancefield group A? Who is Lancefield?
So it belongs to group A beta hemolytic streptococci. So
But why it is that called Lancefield? Lancefield.
the person who found it.
Very good. That's a good guess. But who is that person? Which country she belongs to? And what is her speciality about her?
Community medicine.
How can a community medicine person be making it? She must be a microbiologist. She is the first lady microbiologist of the United States of America. Okay, and she diagnosed, or she made this classification of the beta hemolytic streptococci into group A, group B, group C, and all. So, who designed the Apgar score?
Virginia Apgar.
Virginia Apgar. What is special about her?
And
She is an anesthetist.
She is the first lady anesthetist of the United States. Just like Lancefield is the first lady microbiologist of the United States, Virginia Apgar, actually she wanted to become a vascular surgeon. But suddenly she changed her idea and started doing a residency in anesthesia and became the #1 first lady anesthetist of United States. And she only designed the Apgar score for evaluating the neonate immediately after birth. So like that, Lancefield also carries the credit of being the first lady microbiologist to classify these organism into that. So what is why it affects the mitral valve more than the other valves? Rheumatic fever, when it is recurrently happening, why it affects the mitral valve more than the aortic or pulmonary or tricuspid valves?
So it is the largest valve with more fibrous tissue, also which is exposed to more wear and tear.
Where
velocity.
shear force is more, shear force exposure is more, and that is the largest valve. So naturally, the organisms affect that first and then produce that. Will it always be a stenotic lesion?
When it is
Rheumatic valvular disease, should it be only a stenotic lesion, or can it be a regurgitant lesion also?
it can also be a regurgitant.
It
Usually
may be
acute conditions.
combined with both stenotic as well as regurgitant lesion. Okay.
Yes.
So what is the structure of a mitral valve? How will you describe the apparatus, mitral valve apparatus?
So it has a leaflet, chorda tendineae, and the papillary muscles attached to the walls of the ventricle, sir. It has two leaflet, a small anterior and a large posterior leaflet, which has the chorda tendineae, which is attached. One end is attached to the free end of the valves, and the other end it is attached to the papillary muscles.
Okay. What about the annulus? That is the basic ring. Okay. The annulus is there. What is the importance of this annulus? When you take an ECG, does the annulus has any role to play in that? In a normal patient, not only in mitral stenosis, in any patient, the mitral valve annulus, the tricuspid valve annulus, do they have a role in the waveform or the graphical representation of your electrocardiogram? Why there is a PR interval? There is a gap between P wave and R wave. We call it as PR interval.
AV nodal delay
AV nodal
happens.
delay is
Delay. So here this fibrous tissue takes time to conduct the impulses from the atria to the ventricle. Okay. So that is the reason for the gap between the P wave and the onset of R wave, because of this particular tissue which has a little bit lower conductivity. And this annulus, which part actually gets affected of all these components of the mitral valve, like your annulus, the valve leaflets, the chorda tendineae and papillary muscles? Which portion of the valve gets affected first?
Leaflet.
Entire leaflet or a particular part of the leaflet?
It is usually the base, the attached ends.
Attached end. Is it not
Near
the
the
commissure?
Yes.
It is the commissural, okay, because they are the ones which come and oppose each other when the valve opens and closes. Because they touch just like the lips of a person, they come and kiss each other and then separate. So the maximum wear and tear or shear force happens at the commissural level, and that is why the first effect will be on the commissure, causing commissural narrowing. That is why if only the commissure is affected, we can get away with simple commissurotomy. We can just split the attachment between the lips of the two leaflets and open it out and widen the passage or the valve area. Whereas, what are the contraindications for commissurotomy?
Sir, if the patient has pulmonary artery hypertension or a thrombus in the leg, or the entire valve is calcified and
Calcification, that is more important. Okay, the structural abnormality. If it is only a commissural thickening and attachment, then definitely patient will have a better life quality after a commissurotomy. On the contrary, if the entire valve is heavily calcified because of the wear and tear and the infection, then breaking that will be very difficult, and it is not advisable to go ahead for a commissurotomy by in these conditions. So, well, that is why the Wilkinson score is very important to decide whether the patient can be benefited by a simple commissurotomy, either by a closed method or by an open method, rather than by going in for more extensive procedures. And the second point is the patient should be at a particular age where a repeated rheumatic fever attack is not likely to happen. So normally they outgrow after they become adults to get a recurrence or repeat infection of rheumatic fever. It is the recurrent attacks with a particular strain of beta hemolytic streptococci which causes the damage to the valves. It is not the first single attack which will cause that. So it may be clinical or subclinical. So in this context, they can ask you about the Duckett-Jones classification of rheumatic fever presentations. What are the major and minor criteria which are important to make a diagnosis of rheumatic fever?
So major criteria includes pancarditis, arthritis, sydenham scoria, subcutaneous nodules, and erythema marginatum, sir. Minor criteria includes history of fever, throat infection, raised
Throat
ESR
infection is
and
not a throat infection is not a criteria. Fever, arthralgia, C-reactive protein,
ESR
EKG
and
showing a PR interval prolongation, and ESR being high. Okay, these are the five things which are considered are minor: fever, arthralgia, elevation of C-reactive protein, EKG showing PR interval prolongation, and ESR elevation. So you can remember by the mnemonic phases: F for fever, A for arthralgia, C for C-reactive protein, E for EKG prolongation of PR interval, and S for sedimentation rate increase. That will be the clue or the mnemonic to remember the minor criteria. And major criteria you can remember by the mnemonic ACEs. You just take the F from that and say ACEs. And A can be arthralgia or polyarthropathy, and C can be carditis and chorea, and E can be erythema marginatum, and S for subcutaneous nodules. Okay, so that is the way. So 5 points for major criteria and 5 points for minor criteria. So they ask you these things also suddenly in the exam. So it is better to so either two majors or one major plus two minor. They say it is a confirmatory clinical evidence of rheumatic fever. Clinical and investigatory evidence of rheumatic fever. Okay, and which socioeconomic class group people are affected by this rheumatic fever? Is it coming in the affluent and well-to-do people, or is it in the low socioeconomic group people?
low socioeconomic.
So it happens because of the lack of hygiene. It happens usually in the lower socioeconomic strata of people. And you must ask about history of whether the diagnosis of rheumatic fever was made based on these findings, and what was the treatment given, and any long-term prophylaxis was given for the patient or not. That is a very important history that you should elicit in these patients. So what is the long-term prophylaxis needed if a patient has been diagnosed with rheumatic fever, and that too some involvement of the cardiac tissues are also made out during the diagnosis? What is the long-term prophylaxis and how long should it be continued?
So with carditis, it should be lifelong prophylaxis.
What is the drug
Without
to be
carditis, benzathine penicillin 1.2 million units every 4 weeks, sir. Or oral penicillin B 250 milligram twice orally.
Very good. So if there is no carditis, it is only the minor criteria plus one major criteria of arthralgia, then when can you stop the prophylaxis?
It is for 5 years till 21 years
Till
21 years of
very
age,
good.
sir.
Very good. So up to 21 years, it should have been continued. So you must elicit all this history, even though now the patient is 24 and she was diagnosed with the cardiac problem 2 years ago, and it was of if it is a rheumatic origin, all this history should have been elicited, and whether she received any prophylaxis up to 21 years or not, and whether this problem started afterwards, and what is the progress of this disease, how it started, whether is it very mild initially, going on to become more and more severe. Now that the history says that she is dyspneic even at mild exertion. Is mild exertional dyspnea, is it because of the physiological changes that have happened in the pregnancy which is causing the problem, or it is an advancing disease process of the cardiac valve? How to differentiate between the two? What are the physiological changes, normal physiological changes, which will affect a patient with a mitral stenosis? In what way it is going to
Sir,
cause problem because of
it
the
is
narrow valve?
aggravated by increase in the heart rate, increase in the cardiac output.
Increase in the, what is the first and foremost thing that increases in
Increase
pregnancy
in the
in
blood.
cardiac?
Increase
Blood
in the
volume.
blood.
That is the first and foremost thing. So there is an increase in blood volume. So preload will automatically increase or decrease?
Increase in the preload, sir.
Increase in the preload, and the valve is narrow, so it is not able to empty completely from left atrium to left ventricle. Cardiac output is not completely matching the preload and input, so there is always a stasis. So left atrium will start increasing in size. That will reflect on to the pulmonary circulation, gradually go on to produce pulmonary overload and pulmonary hypertension. Okay? That is the pathophysiology that can happen. So this will definitely affect because of the physiological changes that are happening in that. When will it be the maximum? What is the time the maximum blood volume happens in a pregnant patient, in a normal pregnant patient?
During pregnancy, it is around 20 to 24. At the end of second and the starting of the third trimester.
Third trimester, yes. The maximum blood volume is achieved at the third trimester. Okay, that is the time. But this patient is now almost completing her second trimester and going on to the third trimester. So there is the possibility that all this exertional dyspnea could be due to the increase in blood volume that is naturally occurring because of the pregnancy changes. Now, what are all the goals to maintain preserve the function, whatever it is happening in the cardiac status of a mitral stenosis patient? What are all the goals to be achieved with regard to the cardiovascular system, like preload, afterload, contractility, rhythm, rate, etc.?
We have to maintain low normal heart rate, sir. And we have to maintain sinus rhythm. We have to maintain adequate preload. We should not overload. At the same time, we should not decrease the
reduce the preload. What about the afterload? Should it be maintained, or we can have a dilatation?
We have to maintain, and we have to avoid sudden decrease in the afterloads.
SVR or afterload. Okay. So,
yes,
but in a normal pregnancy, what happens to the SVR?
It is decreased, sir.
Decreased. Okay. So that is another determinant for the normal cardiac function in these patients, because there is an increase in preload, there is a decrease in afterload. So the common mnemonic I used to teach is PACRRI. P for preload, A for afterload, C for contractility, R for rate, and R for rhythm, and the final I for ischemia. So these 6 points, PACRRI. If you remember that, you can describe any valvular lesion and how to manage in each and every case. For example, on all regurgitant cases, what should be the rate? Should be higher or lesser?
Higher, sir.
It should be higher. Okay. So, whereas in the stenotic lesions, the rate should be lower. So, in fact, if you read Barash, it says for mitral stenosis, the heart rate should be low, low, low. That is how they describe in that book to mean drive home the point that you should remember that tachycardia is the most deterrent thing for a mitral stenosis patient. So as long as you maintain the heart rate between 60 and 70, they will do very well. And if they happen to, what happens if there is a tachycardia in a patient with mitral stenosis? What is the adverse thing that can happen?
Sir, it increases the myocardial demand at the same time, decreases the
Are you
supply
worried
to
about the myocardial demand in a young patient like this? Because that is the reason?
Backflow will increase, sir. More prone for pulmonary edema.
Very good. So patient will have lesser time for left ventricular filling. Okay, that is the answer. Whenever the heart rate increases in a patient with a narrowed valve, the left ventricular filling will be inadequate because of the lack of diastolic time. And so blood will start accumulating in the left atrium, and that will get reflected to the pulmonary circulation. And the acute pulmonary edema is a life-threatening complication that can happen because of tachycardia in a mitral stenosis patient. And that is the reason why they say you should keep the heart rate low as possible. And so that is all these things should have been elicited in your history because this patient has already been diagnosed with the disease. And intraoperatively, you said first and foremost thing is to assess the valve size and the severity of the clinical symptoms and the patient's ability to do the normal metabolic, physical efforts, and to decide whether to go ahead with the pregnancy. Of course, at 24 weeks, it is very difficult. The counseling should have been done when the patient has come to the gynecologist first with a positive pregnancy test. They should have told you first consult a cardiologist, get a clearance whether you can go ahead with the pregnancy or not. And if the cardiologist feels that her heart condition is not conducive to continue with the pregnancy, she should have been advised to terminate the pregnancy at that stage itself. But probably because the patient did not feel that much of strain or the exertion at the time, she has continued with her pregnancy and now got into the situation. Now let us say assume that this patient has been evaluated and she has a moderate narrowing of the valve. As you said, normal size is 4 to 6, and symptoms start appearing only when the valve reduces below
2 centimeters.
2.5 square centimeter. And that is called mild. 1.5 to 2.5 square centimeter is called mild narrowing. So patients can definitely manage a normal vaginal delivery or an operative delivery. Whereas when it reduces from 1.5 to say less than 1, it becomes moderate. Less than 1 to 0.9, it becomes very severe, and less than 0.6, it becomes critical. These are the categories of the severity based on the valve area size. So we have to assess that and discuss with as you said, it's a multidisciplinary procedure. So we have to discuss both with the cardiologist and the gynecologist to see whether the patient's pregnancy can be allowed to continue until the maturity of the fetus. That is also another important thing, because at 24 weeks, if we try to terminate and deliver the baby, it will be a very, very premature child unless we have very supportive neonatal intensive care. We cannot salvage the child. So it is better to allow the maturity of the fetus as much as possible in the mother, and decide about terminating the pregnancy 34 to 36 weeks. That will be the ideal time to have a baby which can survive without much complications. So these two decisions have to be taken, whether to deliver the child immediately, if provided we have a good NICU care, or to allow the continue the pregnancy till the baby gets some amount of maturity and then deliver. And the second question is whether to allow for a normal vaginal delivery, provided there are no obstetric complications like cephalopelvic disproportions or other criteria, or whether to go for an elective cesarean section or whether to go for, you may land up with an emergency situation after allowing a trial vaginal delivery also. These are the three possibilities. Okay, normal vaginal delivery, elective cesarean delivery, or an emergency cesarean delivery after a trial vaginal. These are the three possibilities we have to be ready to face. So if we are planning to have, it is a moderate mitral stenosis, we are planning to go for a normal vaginal delivery, and in that case, as you rightly said, the labor pain is the most important thing which has to be avoided for a patient with mitral stenosis. Why?
Tachycardia,
Again, it
sir.
will lead to tachycardia
Pain
and
can aggravate the
Again, yes. Always remember, it is a heart rate increase which is going to be the problem. Okay, so pain is going to cause increase in heart rate, increase in sympathetic discharge, and so that is going to be the most important problem for the continuation or the permitting the patient to undergo normal vaginal delivery. But if we can block the pain by adequate epidural analgesia or other form of labor analgesia, then there is no issue of allowing the patient to go for a normal vaginal delivery. Now, coming to the question of giving labor analgesia, the questions in the exam can be completely driven in that direction itself. Okay, so what are all the methods of providing labor analgesia?
so pharmacological and non-pharmacological methods.
Pharmacological, non-pharmacological.
Pharmacological can be intravenous, inhalational, and central neuroaxial blockades.
First, you said non-pharmacological. What are all the non-pharmacological methods?
Sir, hydrotherapy, aromatherapy, TENS, acupuncture.
Water injection, all these things are, and of course nowadays they start giving therapy right from the first term of pregnancy itself, first trimester itself, asking the mothers to come for regular classes to explain them about the labor pain, how to breathe, the breathing exercises, the contraction of the muscles, how they have to cooperate. All these things are being taught in the, and they have tried even hypnotic therapy, saying that I am all right, I don't have pain, I don't have pain. You keep on repeating that, and your mind gets tuned to that particular thinking, and then you don't feel the pain as much as a normal patient. So all these things are non-pharmacological. Pharmacological, what are all the drugs that you can use for pharmacological pain relief?
So routes can be intravenous, inhalational, and central neuroaxials.
Okay.
Intravenously, preferably remifentanil or low doses of ketamine, 0.1 to 0.2 mg per kg IV, or remifentanil.
Remifentanil, in what form you can administer remifentanil?
Infusion, intravenous infusion.
It is a PCA method. It is a patient-controlled analgesia. Okay, so patient is taught how to use the PCA machine, and you can do the infusion with remifentanil. That is considered as one of the recent trends in the labor analgesia. And ketamine, in this particular case, even though it is described for a normal pregnant woman, for mitral stenosis patient, ketamine would not be the ideal drug to use.
Yes,
Earlier, it was what was the drugs that were used in the earlier days of labor analgesia?
Pethidine.
Pethidine was the commonly used drug, pethidine Phenergan combination. Why that has now become obsolete and even contraindicated?
It lead to tachycardia.
Pethidine causes a lot of tachycardia. Why pethidine causes tachycardia?
Sir, it mimics atropine with its structure.
It has the structural similarity to atropine. So it causes the tachycardia, which is not conducive to this. for any patient for that matter. So the use of pethidine as a part of parenteral labor analgesia is now totally contraindicated. Nobody is approving that. What about other drugs like butorphanol, buprenorphine, or morphine for that matter? Are these drugs recommended or not?
Morphine is recommended in cardiac disease complicating pregnancy.
Let's see. But what are the disadvantages of using morphine? It cause nausea, vomiting.
Nausea, vomiting, pruritus, and
Pruritus, nausea, vomiting. What about fetal depression?
Fetal respiratory depressions.
So these are all the unwanted side effects which are not ideal to use morphine. And the other partial agonist antagonists like buprenorphine, butorphanol, all these things are also having the similar problem of side effects which are not conducive to usage of that. And what about inhalational agents?
Sir, Entonox is used for labor analgesia, but patient with MS, they have pulmonary artery hypertension, it is contraindicated.
Contraindicated. So that is not also an ideal thing. What is the next alternative?
Central neuraxial approach, sir.
Any other inhalation agent?
Sevoflurane, sir. Sevoflurane.
Cevox. There is a combination called Cevox. Just like Entonox, you have Cevox, sevoflurane in oxygen, which is also now currently available in the Western countries, and that is also being used. But what are the disadvantages of using these inhalation agents?
So uterine relaxation and
Premature relax.
atonic PPH.
Atonic PPH. Patient on and off loses the consciousness, okay? And it is not a continuous analgesia like your epidural or other methods of analgesia, okay? In between, patient will start feeling the pain, then they have to again keep the mask and inhale and then get rid of the pain. So during that brief period, patient may have a tachycardia and all the unwanted effects of the pain. So that is also not an ideal route. Now ultimately we land up with the regular old conventional method of epidural analgesia for labor pain relief. But here what is the caution that you have to take if you plan for a labor epidural in a patient with a moderate degree of mitral stenosis?
So patient will be on anticoagulants during their pregnancy.
No, if that history you elicit, if there is no atrial fibrillation and there is no use of anticoagulants, then you can still perform labor analgesia with epidural. But during the epidural, what is the most important precaution you have to take?
Hemodynamic instability because of large dose of local anesthesias. Large volume.
Doses, that is
Co-loading.
always, you have, that is always there. Hemodynamic instability you want to avoid in any patient, not only in mitral stenosis. But what is the most important change in the cardiovascular system you want to avoid by the epidural?
Hypotension and tachycardia.
Hypotension, systemic vascular resistance decrease. Okay, so the sympathetic blockade is the first thing that will happen, whether by epidural route or by your intrathecal route. Whenever you give a local anesthetic central neuraxially, the order of blockade will be autonomic nervous system, sensory nervous system, then motor system. Okay. Earlier they were giving very high doses like even 0.5 and 0.25 bupivacaine because they were giving a longer duration of action, but it resulted in considerable motor weakness in these patients, and they could not ambulate or they could not cooperate for pushing the baby down. So they started reducing the concentration of that drug. So what is the current concept in the usage of dose and concentration? What are the terminologies that are used?
Walking epidurals.
Walking epidural is the preservation of motor blockade. But with regard to concentration, have you heard of MLVA and MLVD?
Yes, sir.
What is that? Minimum local anesthetic volume analgesia or minimum local anesthetic dosage, volume dosage. Okay, these are the two terminologies that they are using in the current concept. And from
10 to
0.5, it has now been reduced to 0.125 and even 0.0625. That is the lowest concentration that has been used. And so by using the minimal low volume concentration and the dosage, you can achieve the desired effect. And still, even then, you may have some amount of sympathetic blockade, because our autonomic nervous system requires very high concentration or very low concentration.
Very low concentration.
Why they require very low concentration?
They are more sensitive, and
Why
the
they are
size
more
of the
sensitive? The size of the nerves. Okay, the size of the nerves. So the blockade of the nerve depends on the size of the nerve. So thicker the nerve, it requires more concentration. Thinner the nerve, it requires less concentration. So the autonomic fibers are supposed to be the smallest nerve fibers, and so they get blocked easily first. And which one will recover first? Which is the order of blockade and which is the order of reversal of blockade?
order of blockade is C fibers, then B, which is equal to
So
A
broadly,
fibers.
autonomic, sensory, motor, what is the order of blockade when you institute the central neuraxial blockade with local anesthetic? What is the order of reversal or recovery?
Recovery is
Motor,
first is
sensory.
motor, then sensory, then
So the blockade starts from autonomic, sensory, and last blockade will be motor. Whereas recovery is in the reverse process. Motor recovers first, sensory recovers next, then autonomic recovers. Okay, so even though the vasodilatation or the reduction in SVR produced by autonomic blockade will be there even with a very low concentration. So how to avoid that? How to prevent that vasodilatation, which is not conducive for a patient with mitral stenosis? Because already physiology of pregnancy itself is causing some reduction in SVR, and further reduction by even a very low concentration of local anesthetic can aggravate this problem. So after load will be very much decreased, and patient will not be able to compensate for that increase in the volume by increasing the cardiac output, because they are in the fixed output state. So how will you plan your labor analgesia, even though you are going to use only 0.0625 concentration? How will you avoid the vasodilatation or reduction in LCR?
sir, we can use vasopressors like
Which
phenylephrine.
vasopressor? Specific phenylephrine, yes. So you prepare an infusion of phenylephrine and start it concurrently, so that you will have the effect of the, you can negate the effect of the vasodilatation. And what is the other advantage of using phenylephrine?
Reflex brady, sir.
It will not cause
Reflex
acidosis,
bradycardia,
sir.
yes. So it will reduce the heart rate also. Okay, so there are two advantages. It will increase the or optimize the SVR, and it will decrease the cardiac heart rate by reflex bradycardia because of the increase in pressure, which is an advantage for mitral stenosis patients. So this point has to be clearly understood by you, and this is very useful in practice also. When you give spinal for a patient with mitral stenosis for cesarean delivery, the drug of choice for counteracting the hypotension or vasodilatation is phenylephrine and not ephedrine, which you are normally using in all patients with spinal hypotension. Okay, so that is the point that you have to keep in mind. By doing that, you can allow a normal vaginal delivery also. So this is another point which you have to think of. And the interventions, you just stopped with balloon valvuloplasty also, and you said about the ideal time to do about that. There are sometimes examiners who, especially if they are cardiac anesthetists and they come for exam, they may ask you about doing a mitral valve replacement during pregnancy. How do you go about that? Is it safe to go ahead and do a mitral valve replacement if the valve stenosis is very severe?
Sir, if it is more than 26 weeks, we can do a cesarean section followed by cardiopulmonary bypass.
But if you want to continue with the pregnancy, is it advisable to do the CPB or not?
No, no.
It always carries a higher risk for the baby. Okay, so that is the reason why they don't normally allow. They try to deliver the baby either by your emergency cesarean and then do the bypass in the same sitting, or manage the delivery and then in the postpartum period they can plan for a replacement. Okay, so that is the only thing that is missing in your presentation. Otherwise, all the other things have been done very well. Just I will share my screen and just give you the points that I have